So my name is Boon. I'm a consultant cardiologist and I run the Imperial Syncope Diagnostic Unit based at Hammersmith Hospital in London. The most important diagnostic steps in syncope is really the history, and you can't place enough emphasis on the history. So when we teach medical students or doctors about syncope, the three key steps in terms of the diagnostics would be history, and I make no apologies for saying history a third time, because it's all about the history. If you ask me about two other things to do in addition to the three that I've said, then it would be a 12-lead ECG. And here you're looking at the ECG as a global marker of cardiac risk stratification, and oftentimes in your syncopal patients who are otherwise young and healthy and fit, which is the majority of the population of patients you will see, the ECG will be recorded as normal. The final bit of the diagnostic stratification comes from the clinical examination, and here what you're looking for is a blood pressure both whilst lying down and standing up, and you're looking for a blood pressure fall on standing by 20 millimeters of mercury associated with reproduction of the symptom profile of pre-syncope, that is to say feeling dizzy, lightheaded, short of breath, perhaps with some chest pain and anxiety. And if those symptoms occur with a blood pressure fall when you stand up and you have your blood pressure recorded, then it is characteristic of orthostatic intolerance. So in summary, take a history, a very good one, do a clinical examination, including listening for a murmur of aortic stenosis, as well as a blood pressure measurement, and a 12-lead ECG. First and foremost, every patient with syncope, if the diagnosis is vasovagal syncope, should be given conservative lifestyle advice. And this should be done very well to inform the patient and educate the patient about the pathophysiological mechanisms that create the ability for the patient to have syncope. And this part of education of the patient, in my opinion, is the most important bit about getting the patient to engage. So even before talking about what strategies to use, including the conservative strategies, we need to explain to the patient why they're having faints or syncope. Once we've established that, then the major conservative advice to give would be to increase fluid intake, and that's aiming for front-loaded fluid intake, which simply means drinking more at breakfast time, at lunchtime, and perhaps not pushing so much fluid in the evening before you go to sleep, because otherwise you might be waking up several times a night to go to pass urine. So fluid intake should be approximately 3 liters, with the bulk of that delivered by lunchtime. Let's say 2 liters by lunchtime and a further liter by 5 p.m. The second strategy is, if you know your blood pressure is on the normal or low normal side, then be free to use salt. Now, you can succumb to your salt craving. Your body has a very uncanny way of telling you how much salt you need, and if it's telling you, I crave salt, succumb to your salt craving. If you don't have a salt craving and your physician has told you that you have to have more salt, how much salt do you have? Well, 5 to 10 grams is what is recommended, and to take that, you need to take something like 1 to 2 teaspoons of salt in your diet, typically, and encourage it, and I would encourage you to take it first thing in the morning with breakfast and at lunchtime, and perhaps not so much again like fluid at dinner time. So fluid and salt are the two major conservative strategies, the third one being avoidance strategies. Most people with vasovagal syncope, when they can recognize what the trigger factors are, for example, being in a warm, hot room or standing for a long time in an underground commute on the way to work, you can learn to avoid or ask for a seat, for example, if you're standing up for a long time. And these avoidance strategies are what's going to get you out of jail most of the time. Now, if you become pre-syncopal, that is to say you start to feel dizzy, sweaty, and you know you're going to pass out, then for goodness sake, don't try walking around dangerous areas. For example, your bathroom with the vanity unit ready to knock your head. but sit down immediately on the floor. And so you don't have a very long way to go if you do pass out, if you know you're going to pass out. So take early evasive action, which is sitting down and getting to a safe position, ideally elevating your feet, and not allowing any good Samaritan to lift you up to only trigger the situation and make it worse. Taking precautionary measures. For example, if you're feeling unwell, then avoiding that long underground commute or going in non-rush hour time so that you don't have the crowds and the stifling environment to contend with. Fluids, salt. And these are your key conservative strategies to try and mitigate the risk of vasovagal syncope. The best way to explain why you're susceptible to fainting is generally to talk about circulating volume, blood pressure, and blood pressure to the brain. Now, imagine your body has got a circulating volume, which includes blood that's pumped from your heart into the brain and into the big toe. It's, in fact, every organ of your body needs to have this flush circulation. And you have approximately, for the average size individual, 5 liters of blood going around. Now, when we stand up, because syncope, typically vasovagal syncope, is a very, very posturally related phenomena, which means you're fighting gravity. And when you stand up, the huge reservoirs of blood, which are in your lower limbs, akin to, say, bottles of water, are now being filled with gravity by blood that is stuck in your heart and your brain, and this pooling of blood that occurs to take away, for example, 800 mils of blood, up to 18 to 20% of your circulating volume, will then get parked into these lower limbs. Now that creates a slight tension because your heart is now empty or emptying into the blood pool by about 20%. And what that creates is a very unique set of circumstances. When your heart's contraction volume doesn't push out as much blood as it used to when you were lying down, it activates these mechanoreceptors. So they are very sensitive baroreceptors on either side of your neck that stretch with every heartbeat. When the volume is reduced, they don't stretch as much. And if they don't stretch as much, it sends a panic signal to your brain to activate what's called a fright or flight response. This is also known as the sympathetic nervous system response. And what it does do is it creates an adrenaline surge, which is why, exactly why, when you feel pre-syncopal, that is to say your blood pressure is falling, literally in your boots with standing, your heart is activating that baroreceptor response in your carotid bulb, and you activate the adrenaline or fight or flight, you get the effects of adrenaline, that is shortness of breath, chest pain, anxiety, feeling hot and bothered, feeling nauseous, and these are the symptoms that you might get before you lose consciousness. Now, if you leave that unchecked, for example, if you continue standing in that warm environment and the blood continues to pool, there will come a point in time at which your blood pressure continues to fall despite the very, very strong adrenaline surge that you have, that reflex. And at that point, you lose consciousness. And at that point, there's very little that you can do apart from get yourself into a safe position, which is getting down onto the floor so that you don't hurt yourself. So the major drug treatments that your doctors might prescribe for vasovagal syncope include midodrine and fludrocortisone. Midodrine is a drug which is called a peripheral and splanchnic alpha agonist. What does that mean? That means when you take the drug, it causes a vasoconstriction. These blood vessels, which are liable to open up and pool and take away blood when you're standing, can be squeezed down by this drug. Midodrine as a drug is taken typically 3 times a day. It's a very short-acting drug, so you can take the smallest dose, and within 15 to 20 minutes after waking, or after taking the drug, which you should take after waking in the morning, what can happen is that the vasoconstriction is maximum, and you will feel that surge or that return of blood back into your heart, and you'll feel better. It wears out, though, after about 4 hours, and so the way we would prescribe it is first thing in the morning, and then 4 hours later, and 4 hours after that. For example, 7 a.m., 11 a.m., and 3 p.m. And we would not recommend taking this drug at night before you go to sleep, nor would we recommend that you lie down after taking this drug. This is a commonly prescribed drug if you have symptoms of orthostatic intolerance or a tendency to faint. Now, the second most common drug is called fludrocortisone, and this is actually a mineralocorticoid. It's a weak steroid drug that acts at the level of the kidneys to promote reabsorption of sodium. Now, sodium chloride is salt, and so if you reabsorb salt, you have more fluid or more circulating volume, and again, you reduce the tendency to vasovagal syncope. And these are two of the most common drugs that are prescribed for vasovagal syncope. The other drugs that you might come across, which includes beta blockers, ivabradine, antidepressants, do not have such a strong evidence base. Your doctor, at his or her discretion, in discussion with you, typically after you have not responded to the other drugs, may choose to implement these other drug strategies, but oftentimes the first two are the most commonly ones used.